As I promised to make an explanation video of my previous video, that was edition papers 2018-19 endodontics part 2, I have selected some questions from that previous video to explain the answer. So the first question that I have selected to explain is number 9. Deep invasion of root dentin by resolving tissues that extend into the coronal third of root comes under which class of Hither's classification? Here the answer was C, that is class 3. So we'll go to the explanation part to understand the Hither's classification. So here is the explanation part. Invasive cervical resorption. External invasive resorption, not external, external invasive resorption, also termed invasive cervical resorption, is given by Hither's. In this, the pulp remains unaffected until late in the process, owing to an apparently thin and resorption resistant layer of dentin and predentin. This separates the pulp from the ingrowing tissue that is initially fibrovascular in character but becomes a fibroosseous type of tissue. We are talking about resorption, that is external resorption, and that also starts in the cervical region. If there is external resorptions, it will not affect pulp at the first time. As it ingrows, there will be a thin layer of predentin and dentin that helps to pulps remain unaffected, and the ingrowing tissue that is replacing the dental part or hard tissue is fibroosseous type of tissue. So this much you can understand. Now next, if exposed to the oral cavity, the pulp will be invaded by microorganisms. Yes, when that resorption further goes near the pulp and it exposes the pulp, external resorption, then there is a communication of pulp with the oral cavity, because the resorption is in the near cervical region. So if it touches the pulp, that there will be a communication with oral cavity. Although pulp vitality can be maintained if there is early diagnosis and treatment of this type of resorption, or extensive lesions require non-surgical root canal therapy and resorption treatment if the tooth is to be maintained. So the treatment is root canal treatment mainly. So now we'll go to the classification. You can see class 1. Class 1, this is the cervical invasion resorption, very small. So in class 1, the definition is small invasive resorptive lesion near the cervical area with shallow penetration into the dentin. So it is near the cervical area and the penetration is shallow. Now next, class 2. Class 2 is well defined invasive resorptive lesion that has penetrated close to the coronal pulp with little or no extension into the radicular dentin. So the catch point is that this resorption is approaching towards the pulp at the cervical region, but it hasn't extended into the radicular dentin. Radicular dentin, there is no extension. It is only present at the coronal part. Now class 3, deeper invasion of root dentin by resorption tissues that extends into the coronal third of the root. So it approaches towards the pulp at the cervical region, as well as it extends, the resorption extends at the radicular part of dentin too, but it is in the coronal third of root. It is not goes beyond the coronal third. Now this is, you can see, this is large invasive resorptive process that extends beyond the coronal third of the root. So it extends beyond the coronal third of the root. So you can take a snapshot for better understanding. Now classification, this is the class 1. Take a snapshot. Now these are class 2, class 3 and class 4. I just read it out. Now the next question that I have selected, classification of Kim's microsurgical endodontic case having a large periapical lesion approaching coronally with no pocket and no mobility. The answer was C, that is class C. So we'll go to the explanation part to understand Kim's microsurgical endodontic case classification. Let's go. So where is the explanation? Singu, Kim and Crashman classified endodontic microsurgical cases periodicular lesions into category A to F. Now class A represents the absence of a periapical lesion, no mobility and normal pocket depth, but unresolved symptoms after non-surgical approaches have been exhausted. Clinical symptoms are the only reason for the surgery. So there is no lesion, periapical lesion, no mobility, but there is a symptom still going on after the root canal therapy and re-RCT also. Then intentionally we are going to the surgery, periapical surgery. So this is class A. Now class B represents the presence of a small periapical lesion together with clinical symptoms. The tooth has normal periodontal proving depth and no mobility. The teeth in this class are ideal candidates for microsurgery. So class B, there is small periapical lesions as well as clinical symptoms also. Now class C, teeth has a large periapical lesion progressing coronally but without periodontal pocket and mobility. Now class D, features are clinically similar to those in class C but have deep periodontal pockets. Now class E, teeth have a deep periapical lesion with an endodontic periodontal communication to the apex but no obvious fracture. Class F represents a tooth with an apical lesion and complete denudement of the buccal plate but no mobility. Now lesion type A, B, C represents lesions of endodontic origin and are ranked according to increasing size of periodicular lesion. Lesion D, E, F represents lesions of combined endoperio origin and are ranked according to magnitude of periodontal breakdown. Class A, B, C present no significant treatment problems and conditions do not adversely affect treatment outcome. Classes D, E, F present serious difficulties. So these are the explanation part. You can take snapshots where needed. Next question that I have selected, number 12. Kim's KIS tip, which is double angled and the tip of which is angulated at greater than 100 degree is, answer was KIS 4. So you will go to the explanation part. And the 13 number question also, Start X3 is used as MB2 scouter, canal opening scouter, metal post removal, reveals the original pulp chamber floor. The answer was B, canal opening scouter. So we'll explain both the questions 12 and 13. So number 12, ultrasonic tips for root end preparation. The first ultrasonic tips of root end surgery are stainless steel core tip, codename CT125. The KIS or Kim surgical tips are coated with zirconium nitride and have an irrigation port at the tip rather than along the shaft. These advanced tips cut faster, smoother, and produce less microfractures with more efficiency in cutting. So KS1, it is designed for mandibular anteriors and premolars, angled 80 degree at the working end, 0.24 mm diameter, 3 mm cutting surface. KS2, designed to access larger diameter roots like anterior, maxillary anterior. The diameter is 0.7 mm and 3.0 mm is cutting surface. Now KIS3, designed for posterior teeth, 75 degree angle, double angled, used for maxillary left side and mandibular right side, maxillary left and mandibular right. Now KIS4, that is similar to KIS3 except that the tip angle is 110 to reach the lingual aspect of molar root. Now 5, counterpart of KIS3 for the maxillary right side and mandibular left side. So KIS5 is exactly same as KIS3 but the counterpart. Like KIS3 is used for maxillary left mandibular right, here maxillary right mandibular left, and KI6 is counterpart of KI4. So take a snapshot to now next we'll go to the statics. Statics, these are the these are the ultrasonic tips for the access cavity. Simple system, one tip, one clinical indication. A range of ultrasonic tips designed for specific indications. Now, great working precision with an incomparable view of the operative field. Now, Start X1, that is used for access wall refinement. Start X2, MB2 canal scouter. Start X3, canal opening scouter. Start X4, metal post removal. Start X5, revealing the original pulp chamber, floor anatomy. So take a snapshot of these two. Now the next question is 15 number question. Not a cannula in ultrafill 3D. Which is not a cannula? So the answer was D, that is thin set. Now understand the explanation. Ultrafill 3D is a thermoplastic gutta-percha injection technique involving gutta-percha cannulas, a heating unit, and an injection syringe. The system employs three types of gutta-percha cannulas. The regular set is a low viscosity material that requires 30 minutes to set. The firm set is also a low viscosity material but differs in that it sets in 4 minutes. The manufacturer recommends compaction after the initial set with both materials. Endoset has a higher viscosity and does not flow as well. It is recommended for techniques employing compaction and sets in 2 minutes. Cannulas can be disinfected but are not designed for heat sterilization procedures. The heater is preset at 90 degree and does not require adjustment. Each cannula has a 22 gauge stainless steel needle that measures 21 mm in length. The needles can be pre-curved. Heating time varies, but for a cold unit it takes 10 to 15 minutes. In a warm heater, the recommended time is 3 minutes. So the cannula's regular set, it requires 30 minutes to set. Firm set, it is also requires 4 minutes. So the regular set and firm set is low viscosity material. Endoset sets quickly in 2 minutes, but the viscosity is higher. So these are the cannulas. There are one point more, I think. Yes. After removing the cannula from the heater, the needle should be placed on the hot part of the heater for several seconds. The gutta percha remains able to flow for 45 to 60 seconds depending on the viscosity. So the next explanation question is apex sum is used for. Answer was minimally invasive method for the debridement of periradicular tissue. So what are the options for the treatment of periapical lesion? One is surgical, that is periapical surgery. Second, conservative treatment, that is by root canal treatment and by obturation or by placing Metapex or other intracanal medicament and follow up radiograph to check how the healing is happening. So these are the two options. Apex sum is a new procedure. It involves mincing of periradicular tissue through the root canal and also washing out the periapical lesion through the root canal. So there are instruments that goes beyond the root canal to the periapical tissue, and the instrument rotates just like file. It rotates. It minces the periapical tissue and then washed out. There are two types actually. Apex sum, one is apex sum Neet ablator and apex sum PGA ablator. Neet, it used a Neet wire for mincing the periapical tissue, and the RPM is less, 200 to 300. And in apex sum PGA ablator, the used a biodegradable filament and the RPM is 5000 to 7000. So this is the apex sum. Next question, Kroll techniques used 11% HCl, 12% EDTA, 37% H3PO4, 2% MgSO4. The answer is A, that is 11% HCl. So we'll go to the explanation part. So Kroll technique is a micro abrasion technique. So we'll go through some historical background. McKinn's, a mixture of 5 parts of 36% HCl, 5 parts of 30% hydrogen peroxide and 1 part ether as a topical treatment. Morin and Berkmeyer applied 36% HCl just like the McKinn's with pumice to the enamel surface with a slowly rotating rubber cup for up to 5 minutes to remove stains in the enamel. Afterwards, teeth were bleached with 30% hydrogen peroxide along with heat application and finally applied topical fluoride. Now, Kroll and Kavanagh, 18% HCl, pumice and water mixed to form a paste to remove the enamel discoloration. Now finally, our question, Kroll's technique. Further modified the technique, reducing the concentration of HCl acid to approximately 11% and increasing the abrasiveness of the paste using silicon carbide particles in a water soluble gel instead of pumice. So these are the explanations. If possible, take a snapshot of this. So these questions are the explanation from the part 2 video. If you are new in this channel, please go through the part 2 video, then come this to this video for better understanding. Thank you very much for patience listening.